We've come a long way in our understanding of vision. Started off with our understanding of the anatomy of the eye and how from there's a trajectory, a pathway that allows it to travel through the optic chiasm over to the thalamus, specifically the LGN. From there, it goes over to specific parts of the striate cortex. In this module, we will learn and discuss different cortical mechanisms of vision, because reaching the striate cortex is the beginning of an output that the brain will generate depending on what the object or what the sight is. There is much more to the human visual system than just the eyes. The entire occipital cortex, as well as the large areas of temporal cortex and parietal cortex, are also involved in vision. Here you can see a flow of visual information going from the eye, specifically to the LGN, impacting the primary visual striate cortex, but then having the ripple effect we mentioned earlier, and going over to the prestriate cortex, also known as secondary, and then from there making their way even outside of the occipital lobe. Notice here they're making use of the temporal cortex, more specifically the inferotemporal cortex, and here we're making use of the posterior parietal cortex. Please note that these lobes here are not involved in vision, but they assist based on what was perceived by the brain. The flow of visual information, again, is going from the thalamus to the primary, which is here, to the secondary, which is here, and then eventually to what we call association cortex, and it'd be for the visual here as well as here. As the visual information flows through a hierarchy, we start talking about a hierarchy, meaning like a ranking. Like in a business model, you would have the CEO at the top, and then you'd have the individuals that work at the stores at the bottom. There's an order. The same thing with our system here. Our visual information flows through a hierarchy, and so we would actually start with the perhaps least important, not to undermine their work, but least important, and then most complex and most important. So as we start making our way back, the receptive fields start becoming larger, impacted a part of the retina, but as we start getting to the top here, the ripple effect makes this larger and larger, and so there's a lot more neural activity. They also respond to more complex and specific stimuli, and they also begin to respond to shapes, colors, and etc. You may have heard of people that give advice as to how to look taller or thinner, and they often say things along the lines of do not wear shirts that have horizontal stripes. And the reason why is because your brain would actually be sending information based on what it's sensing, and it would then be perceiving it in the back because it responds to certain shapes and colors. And so when you send something that is horizontal, then you would actually have the perception of the brain that would be this way. However, if you send something to the brain that is vertical, you would be perceiving them this way. And the brain would arrange it in a way so that you could make sense of everything. This is a picture of what's known as the Kinesia Triangle. I want to use this for us to understand whether our ability to see is entirely on our eyes, and if that in any way or in any form plays tricks on our brain. The majority of people that are asked claim to see two triangles here. One of the triangles being here, although we know that it's just angles, and then the other triangle that individuals claim has clear visible lines is what they claim to be a white triangle. In fact, some people go as far as saying that the white in here is different than the white outside. This, if you see the white triangle, it is because of an illusion that your brain is creating. It is not your eyes, it is your brain. Your eyes are seeing exactly what everybody else's eyes are seeing. It's just that once you feed the information through the visual pathway, it's activating specific receptive fields, and it's making us believe, that's the perception component, it's making us believe that there is in fact a white triangle. But if we were to erase this right here, you would see nothing more than a blank blank white background. This is where we start looking at perception and whether we are conscious of everything we perceive or not. Many patients with healthy retinas and healthy eyes actually have extensive scotomas. A scotoma is an area of blindness that corresponds to areas of contralateral visual field for both eyes. In this specific case, we have a scotoma with an individual who sustained an injury to the left side of his head. Because the area of blindness is contralateral to where the damage is, you could see that the scotoma would be this gray area here. And notice that even though the damage was on the left side of his head, the blindness is primarily seen on the right side of each eye. This is not due to retinal damage, but this is due to damage to the primary visual cortex. And you may remember that that is in the occipital lobe in the back. The way we detect scotomas is not from individuals claiming that they have blindness. This is actually done through what we call the perimetry test. If you've gone to the optometrist, they basically put you in front of a screen and there is a small dot that's projected or flashed at various parts of the screen. And the patient is asked to press a button, a clicker, so that they could record whenever the dot is seen. A patient like this gentleman here with scotoma would be able to click the dot, or the clicker, if the dot appeared there, or here, or here, or here. But if the dot appeared here, the patient would not see it. If the dot appeared here, the patient would not see it. But if the dot appeared here, it would not be a problem. And that's how we were able to discover scotomas. Many patients with these scotomas are not consciously aware of their deficits. One factor that contributes to this lack of awareness is something that we call completion. This is a perception of a complete image despite scotoma. And so these individuals would have missing details that are supplied by their brain cognition. This may be possible, we believe, due to residual visual capacities in the scotoma, meaning that although there would be a large area where they're not able to detect things, there may be some islands of cells that would still be responsive and provide them with this ability to complete the image. Here we see an extreme case of a patient, Lashley. This is what Lashley saw because of scotoma. However, Lashley, because of completion, associated with her cognitive process of what makes sense, what head would fill in here, we see that she would perhaps picture an individual that fit a criteria that was associated with her schema. There are examples of patients who suffer from what is known as the hemianopsic scotoma, basically a scotoma that covers half of their visual field. They may see an entire face simply by focusing on a person's nose, even when the side of the face in the scotoma has been covered by a blank card. Damage to the visual cortex, as we see, can be problematic. But of all visual abilities, the perception of motion is most likely to survive damage to the primary visual cortex. For example, a patient with blind sight might still reach out and grab a moving object in her scotoma, all the while claiming not to see it. This is what we would call blind sight. The ability to respond to a visual stimuli in the patient's existing scotoma. This, we believe, is explained by two explanations in here. So as we look at the first one, we look at the possibility that striate cortex is not completely destroyed. In fact, there may be some islands of these functional cells within the scotoma that are capable of mediating some visual abilities. And we believe that that may be enough, that may suffice to then stimulate the rest of the brain and have some type of response when an individual that does not see is still able to respond to it. That's what we call blind sight. The second possible explanation, which also has some support, is that there may be direct connections between subcortical structures and secondary visual cortex that basically bypass the primary visual cortex. These are capable of maintaining some visual abilities in the absence of cognitive awareness. As you may remember earlier, we looked at how the primary process would be going from the eye here. It would travel over to the LGN and then swing around to the primary visual cortex. Well, the second theory would basically state that instead of moving from the LGN and going to the striate cortex, it would go from here, swing around, and then move up directly to secondary visual cortex, thereby bypassing the first component, which would be the primary cortex here, and going over here where we would be able to maintain some visual abilities in the absence of cognitive awareness. You're not able to see it, but you're still able to make some type of response to this in here. This makes sense as there will be a process through which we will stream the information from here to here to an association cortex, and this would get us ready to activate the motor response from our brain. I'll explain that in the next module. As we wrap up this module, please note that neurons in each area respond to different visual cues such as color, movement, or shape, and that is because of the retinotopic layout. You must also know that the lesions of each area would result in specific deficits such as scotoma or something else. We also find that there are anatomically distinct areas that have been identified so far in the visual system. In fact, we find that the most thoroughly mapped species for visual cortex are the macaque monkeys. There are more than 30 different functional areas of the visual cortex, in addition to the primary visual cortex, 24 areas of the secondary visual cortex, and 7 areas of association visual cortex that have been identified so far. And last, the most important takeaway is that our visual system is retinotopically organized, meaning that whatever areas are stimulated in our retina will be seen in the geniculate and at the striate cortex in a similar fashion, and they will remain parallel. So again, if you see something within the brain at the retina that impacts this layer, then at the LGN you'll see a similar stimulation, and at the striate cortex you'll see a similar stimulation. If on another occasion you stimulate cells in the retina that are like that, then you will see a similar pattern, the LGN and at the striate cortex.